Alright, hi everyone. So we are going to see the explanations of season 2 cornea session. There are 10 questions, always like that, and I am ready to give the quiz in the same manner in which if I was giving the test live, what would have been my thought. I will answer like that. So 3, 2, 1, go. So the first question is the problem in which layer leads to bullous keratopathy. See, if I know kera means cornea, I should know that. Means this is related to cornea because this is a cornea quiz, of course. Now bullous means there are some blisters in the epithelium of the cornea. But the answer is not epithelium, because what happens when there is a endothelium cell loss, like in complicated cataract surgery or Fuchs dystrophy, or maybe anything which is involving the endothelium of the cornea, there is a pump known as sodium potassium ATPase pump. If it is not working, the water is not going outside the cornea, there will be stromal edema, which can lead to epithelium edema, that is blisters, that is bullous, keratopathy. So the problem lies in endothelium, not the epithelium. That is why in Fuchs dystrophy, the mostly seen in females, they are presenting mostly corneal edema or blurring of vision maximum in the morning, because in morning, in naturally also, the cornea is slightly thick, because at night the lactate accumulates in the cornea because of aerobic to anaerobic glycolysis, and that can also block the sodium potassium pump. So that's why in Fuchs dystrophy, the patient presents with maximum blurring of vision in the morning. That is bullous keratopathy. Can be seen after cataract surgery, pseudophakic bullous keratopathy or aphakic bullous keratopathy. And when the problem is in endothelium and stromal edema is there, what drug can you give to decrease the corneal edema? That is a topical 5% hypertonic saline that will take out the water outside the cornea by osmosis. I hope you know osmosis, movement of water from low solute to high solute. And the ultimate treatment is replacement of the endothelium by keratoplasty, Desmond stripping endothelium. Keratoplasty is the answer. So that's the first question. Second question is a slit lamp image, a diffuse image, and a very important picture. This is a green is ulcer, and this is the blue light coming from cobalt blue filter, and the dye uses fluorescein dye, which has the property of fluorescence. Everyone should know that. And this is the dendritic ulcer that is classically seen in herpes simplex keratitis. Epithelium is involved, yes. Answer is dendritic ulcer. Stain is fluorescein, yes. Topical steroid is contraindicated, not adjuvant, because that will lead to flaring of the ulcer. Topical acyclovir 5 times a day in ointment form is the treatment of choice. Topical cycloplegics is the adjuvant treatment of choice to decrease the pain, decrease ciliary body spasm. And if it is a viral keratitis, corneal sensations are reduced. That is, you should know about dendritic ulcer. Topical steroids are contraindicated. Now 28 progressive dementia, akinetic rigidity, jaundice, and a ring in the periphery of the cornea means copper is deposited in basal ganglia, liver, and eye. That is Wilson's disease. In Wilson's disease, copper is deposited in Desmond's membrane known as Cases-Flesch's ring, starting from 12 o'clock, 6 o'clock, and then circumferentially spread. But the first investigation is not slit lamp. First investigation is gonioscopy, because the first structure in gonioscopy is Schwalbe's line, and termination of Schwalbe's line is termination of Desmond membrane is Schwalbe's line, and the copper is deposited in Desmond's membrane of the cornea. So gonioscopy is the earliest investigation to diagnose KF ring. KF ring will not have any vision loss. No treatment required for KF ring, but on treatment of Wilson's by chelating agent you study in medicine, the ring reverses. That is also important prognostic sign. Now 25-year-old patient has corneal ulcer 1 year back for treated and healed by scarring. Scarring is there now. Now you have to improve the vision of the patient by keratoplasty, because the posterior segment is normal, no abnormality. Vision is 7/60. So here it is therapeutic is done to, main aim is to decrease the infection. Here infection is healed. Here you have to improve the vision. That is optical keratoplasty. That's the answer. Tectonic is to maintain the shape of the eyeball, that is in anterior staphyloma, and that is tectonic because vision is lost mostly in staphyloma because of high pressures. The optic nerve is already damaged, so that is a tectonic keratoplasty. But here to improve the vision, that is optical keratoplasty. Now the odd one out here is A is keratoconus in the lateral picture. The central paracentral part of the cornea is bulging, and if the patient looks down in down gaze, the lower eyelid bulge, that is a Munson sign. And for treatment of keratoconus, you give there is a myopic astigmatism. Patients are not compliant to spectacles. Rigid contact lenses are given. In early keratoconus, when there is no bulging, soft toric contact lenses can be given. Treatment of choice is corneal collagen cross-linking by riboflavin under ultraviolet A rays, that is C3R procedure. But for non-progressive keratoconus, a PMMA ring, polymethyl methacrylate ring, can be put in the stroma of the cornea to stabilize the cornea. That was also image question asked in NEET exam, last exam, that is intracorneal ring segments or intacs. So A, B, D are towards keratoconus. C is a horizontal Hab stria line in congenital glaucoma. In Booth-Halmos, the cornea stretches. So H for horizontal, H for Hab stria in congenital glaucoma, V for vertical, V for walked stria in keratoconus. So C is the exception over here. That is odd one out because that is seen in congenital glaucoma. Now this picture is showing a defect in the eyelid, in the upper eyelid. So this is a defect, structural defect is known as coloboma. So eyelid coloboma, the most common complication is corneal exposure, because if the patient closes the eye, the cornea and sclera is exposed. Cornea exposure is more important because you see from the cornea. That is the most common complication. But this is not due to failure in closure of embryonic fissure. Embryonic fissure forms a optic cup, and optic cup forms an eyeball. So all the eyeball colobomas like iris, retina, optic disc lens, they are inferior because embryonic fissure is inferior, closed by 36 days. This eyelid coloboma is not. Eyelid is formed by skin of the eyelid and appendages by surface ectoderm. Eyelid coloboma is formed due to failure of eyelid development. That's why the eyelid coloboma can be in upper eyelid, lower eyelid. So that's a incorrect statement over here. The chance of exposure cornea is less if the patient is having good Bell's phenomena, means if the eyeball is rolling up and out. If the eyeball rolls up and out, means good Bell's phenomena because of third nerve, seventh nerve, the exposure of cornea will be less. And D option is yes, only surgical management. There's no medical management for coloboma. They have to suture the two eyelids. Only surgical management is there. So A is the answer because eyeball, remember my words, eyeball colobomas are formed by failure of embryonic fissure, not eyelid coloboma. Now, many of you must have seen this 18-year-old girl came with OPD with pain, redness in eye after wearing contact lens and washing with tap water, and you have answered acanthamoeba. That's why I gave this question. Contact lens can cause any keratitis. Tap water washing can also cause any keratitis. Yes, most likely is acanthamoeba, but look at the picture afterwards. There was a feathery rolled margins with pus in the anterior chamber. Feathery rolled margins goes in favor of fungus hyphae. That's why the answer in fungus over here is fusarium is the answer, not acanthamoeba. That's why you make mistake in the exam. You say it's a very easy question. Tap water, you mark acanthamoeba, you will be wrong. Like penetrating trauma, you answer sympathetic ophthalmia. You are wrong because yes, it is caused by sympathetic, but penetrating trauma in one eye, the other eye involved, that is sympathetic ophthalmia. In penetrating trauma in the exciting eye, there can be anything. There can be endophthalmitis, panophthalmitis. That can also be the question. The other eye is involved due to hypersensitive reaction type 4. That is sympathetic ophthalmia. There also make mistake like this. Here also many of you have made a mistake like this. Here the answer is fungus. Now irregular astigmatism is when the cornea surface is very irregular, like corneoplasty, advanced pterygium, advanced keratoconus. Cave ring, I told you in the periphery in the cornea, it will not cause any vision loss. That cannot cause irregular astigmatism or any astigmatism. Now, this is the sclera is thinned out, lined by uvea because uvea is lining, choroid is lining the sclera, and there is a bulging over here. And bulging is not in the limbus, bulging is in the ciliary body area. So that is a specifically ciliary staphyloma, which can be a complication of scleritis, scleromalacia perforans. And IOP is high, that's why bulging is there. So IOP is not low over here. That's why the answer over here is ciliary staphyloma. IOP should be high, and the optic disc might be damaged. That's why the prognosis is poor. Now this I made a mistake in the question. I corrected afterwards. Although following can lead to corneal edema except formal movement of stromal fluid into aqueous and the IOP is high. Yes, that's why when the acute pressure is very high, more than 60-70, it increases the stromal pressure and the aqueous can imbibe into the cornea. That's why in acute angle closure, congenital glaucoma, there is a hazy bluish appearance of the cornea. Collagen is one most common in the cornea. There is a lamellarly arrangement that is also responsible for transparency. So disorder will lead to corneal edema. This I made a mistake. I wrote avascularity. No, but avascularity is responsible for transparency. Vascularity is a healing process. The vessels come, if there is an infection in the cornea, vessels come with nutrition, but at the end they will become scarred. So vascularity will also lead to corneal edema, opacification. Glutathione is the answer over here because glutathione is responsible for transparency, but not in cornea, but in lens. Okay, so that was my mistake, but I corrected. Always you can correct the mistakes, right? And you should know, you should tell if you are made a mistake. I made a mistake, I accept the mistake. I sorry about that. C option देखो एक और mistake है, B और C नहीं किया mark, तो the C should be the over here, but answer is over D. D is presence of glutathione in the cornea. Okay, again I made a mistake. A man can always admit his mistakes. Thank you very much. Best of luck for listening. Thanks.